It's that time of year again. ACR Convergence 2024 is nearly here. Join us in Washington, D.C. from November 14th to the 19th and meet with colleagues from around the world. Enjoy thought-provoking sessions, listen to groundbreaking science, or join us for the Knowledge Bowl, Thieves Market, and the Image Competition. Register today at rheumatology.org. ACR Convergence 2024, where rheumatology meets.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find all of our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Rheumatologists often encounter patients with complex systemic symptoms that can be challenging to diagnose. Among the differential diagnoses are conditions known as Inborn Errors of Immunity, or IEI. These disorders present with various symptoms, including autoimmunity, autoinflammatory issues, and immunodeficiency. Symptoms can often mimic rheumatic diseases, leading to potential misdiagnoses if IEIs are not considered. Today, Dr. Bharat Kumar will help us to identify patients with inborn errors of immunity who unexpectedly show up in our rheumatology clinics. He will explain what IEIs are, their causes, and their clinical manifestations. He will also discuss the overlap between IEI and rheumatic diseases, the challenges in the diagnosing of IEIs, recent advances in treatment, and practical insights from his clinical practice. Early recognition of patients that may have these conditions and prompt referral to an immunologist can lead to more accurate diagnoses and the initiation of effective, personalized treatments. This episode is essential for anyone looking to deepen their knowledge of the intersections between allergy, immunology, and rheumatology. Dr. Kumar is a clinical associate professor of medicine at the University of Iowa, where he practices both rheumatology and allergy immunology. He completed his undergraduate degree in political science at the University of Pennsylvania and his medical degree at Saba University School of Medicine. He completed an internal medicine residency at the University of Kentucky and fellowships in rheumatology and allergy immunology at the University of Iowa. During his fellowship training, he also completed a master's degree in medical education and certification in musculoskeletal ultrasound. Currently, Dr. Kumar is the physician editor of The Rheumatologist and the Humanism in Research associate editor of the Gold Foundation's Research Roundup. Most recently, he has become the program director for the University of Iowa's Rheumatology Fellowship Training Program and is the co-director of the Iowa City Veterans Affairs Health Services Research Fellowship. Despite all of these many accomplishments, he may be better known as the winner of the ACR Knowledge Bowl multiple years in a row. Enjoy the show. Bharat, welcome to the show.
Yeah, thank you so much for inviting me. It's always a pleasure to talk with you.
Yeah, I think we used to talk to each other from the podium of the Knowledge Bowl. You know, you were one of the repeat winners of the Knowledge Bowl. And it's incredible to see what you've done since. And I'm so thankful to have you on the show to talk about inborn errors of immunity.
Great. Now, as long as I don't need to answer any questions in the form of a question, I am perfectly fine with talking about one of the things that I absolutely love, and those are inborn errors of immunity.
Okay, so as a rheumatologist, why should I care about these inborn errors of immunity? I mean, isn't that stuff that immunologists should deal with and not rheumatologists?
Yeah, so I think rheumatologists need to be very, very well aware of inborn errors of immunity because we see them all the time. Whether or not we actually recognize it, whether or not we actually decide to call them inborn errors of immunity, that's a different question, but we do see them all the time. So before actually diving into why you should care, let's talk about what exactly are these inborn errors of immunity. And it's really a very confusing field in terms of the terminology because it keeps on evolving, just like the field of immunology, right? So inborn errors of immunity, according to the experts, let me just pull up what the 2019 consensus is. The inborn errors of immunity, also referred to primary immunodeficiencies, manifest as increased susceptibility to infectious disease, autoimmunity, autoinflammatory diseases, allergy, and or malignancy. So you see in that autoimmunity and autoinflammatory diseases, already you're seeing where the role of rheumatologist is in terms of figuring out, does this patient have an inborn error of immunity or not? The second part of what was in that little sentence is also called primary immunodeficiencies, which is a term that most rheumatologists are probably passingly aware of, even if they're not familiar with inborn errors of immunity. We do a terrible job in medical school and whatever in residency and whatever in fellowship of explaining what exactly are these primary immune deficiencies or inborn errors. And the reason why is it's difficult. And again, it's moving all the time. I don't like both of these terms. I didn't make them up. I don't know why immunologists and rheumatologists have a tendency to come up with the most arcane and difficult to understand terms, but both of them really don't give a good flavor of what exactly these conditions are. And let me just explain through the holes that exist for why I don't like the term inborn error of immunity and why I don't like the term primary immune deficiency. So first of all, we call it inborn errors of immunity because it's kind of a translation from inborn errors of metabolism, but it's not quite the same. It doesn't translate well, right? So number one, are these really inborn? A lot of these have genetic mutations. We know of at least 431 of them. By the time you hear this podcast, there's probably going to be a lot more of that, literally discovered by the day. Yet, a lot of these patients, they don't have it at birth. Therefore, saying it's inborn is a little bit misleading. Many of the patients that I see in clinic, they have it much later in life. And we know that genes, they turn on, they turn off. There's a lot of epigenetics. There's a lot of somatic hypermutations. There's a lot of germline, it goes on and on and on in terms of the genetics for it. So it's a little bit misleading to say it's inborn. And that's not even getting into the environmental aspects of it. So you can have an inborn error of immunity, but if you are raised in a completely sterile environment, it may not manifest. And therefore, you're not going to have an inborn error of immunity because they're not going to catch it, right? So that's kind of the first problem that I have with it. The second problem is the word error, which I think is incredibly problematic when we talk about patient-centered language. Because what is an error? An error is something that's wrong. It's a mistake. Well, I would contend that none of these are errors or mistakes. They are created for some reason that we just don't quite understand. And many of the things that we've considered errors in the past have turned out to be natural human variation, or it's turned out that they're actually beneficial for whatever reason. So an error, for example, is lactose intolerance, not necessarily an inborn error of immunity, but that's an error. But is it really an error? It served an evolutionary purpose. So that's why I don't personally like the term error. And the last thing is immunity. So yes, obviously, these are immunodeficiencies. We think about it in terms of immunity, but a lot of these genetic mutations that we talk about have pervasive effects that go well beyond the immune system. And now we realize that the immune system touches literally every single aspect of the human condition. And so what exactly is an inborn error of immunity? I mean, the more you examine the term, the more you find these holes, and the more you find philosophically that it's a very hard thing to truly define. So that's why I don't particularly like that term, although it's probably the most precise term that we have right now. And it's probably a step up against the other term that we use, which is primary immunodeficiency. And, I hate to poke holes into everything, but primary immune deficiency is also a problem too. Because number one, for the same reasons that we talked about inborn, these immune deficiencies are very complicated. And things that we thought about as being, quote, primary, actually are a combination of both genetic factors and environmental factors and other factors that we can't even imagine. And so there's no such thing as primary or secondary, and that wall is rapidly collapsing. The second element of the immune deficiency suggests that the immune system is only there in order to serve a singular purpose. And that's why we get, quote, a deficiency. But the immune system does so many different things. And that includes what we classically think of in terms of defending against disease, but also a host of homeostatic mechanisms, right? Preventing autoimmune and autoinflammatory diseases, preventing hyperinflammation. We're just trying to get over this pandemic. It's still out there. COVID's still out there. And we're learning that a lot of the problem has been on hyperinflammation. Now, are we supposed to say that everyone who had COVID had a primary immunodeficiency? After all, they got an infection many of the times. But that's the majority of the population. That means we all have a primary immunodeficiency. So this is kind of the philosophical challenge that exists within the field of clinical immunology, and I would contend within the field of rheumatology too. Because the analog is to say that, is arthritis a disease? Well, I would say it's a disease, but virtually every single person that I know has arthritis as well, right? I mean, so these are very philosophical things that have to do with the human condition. But regardless, there are definitely some genetic mutations that predispose towards the more universal term immune dysregulation. There definitely do exist those kind of things. And again, they fall into a huge spectrum. So some of the inborn errors of immunity clearly fall into that category. So for example, severe combined immune deficiency, in which these children, they get sick very rapidly without any intervention. That clearly seems to be an error of immunity, at least from what we would consider it. And then there are so many other more challenging things about immune dysregulation. So for example, when we talk about HLA-B27, is that an inborn error of immunity? Well, we can stretch the definition to include it, but classically we don't consider it that way. But it does skirt the line. And so I would contend that yes, depending on how you define this term, rheumatologists have a very important role in that. So that's a very long answer. And I could go on and on about that. But the more that I think about this, the more I realize that clinical immunology is swallowing all of rheumatology and all of internal medicine. And I often tell my trainees, both in rheumatology and in allergy immunology, that there's a singularity brewing. A singularity is like a black hole, like the center of a black hole. It just sucks everything into there and not even light can escape. And that's what immunology is doing, clinical immunology. That's not necessarily a bad thing. I'm making it sound like it's a sinister kind of plot. That's just how the science is evolving, that we're learning that the immune system is intimately involved in virtually every single physiological process. And that's why rheumatologists should be aware of what are inborn errors of immunity.
Very cool. I love your philosophical arguments about these things. I used to see the immune system sort of as a two-way thing, that you either have too much immunity and you get autoimmunity and you get, many of the diseases that we see in rheumatology, or you are immunodeficient and you get immunodeficiencies and recurrent infections. But I remember during fellowship, I trained in a program where we actually saw a lot of immunodeficiency patients. And I remember seeing a patient with Wiskott-Aldrich syndrome. And, he had immunodeficiency and autoimmunity. And that's the first time that I began to understand this concept of immune dysregulation, which is what you mentioned, in that the immune system is not just, either or. As you mentioned, the immune system can involve so many aspects: autoimmunity, autoinflammation, my favorite topic, immunodeficiency, allergy. And while we used to think that, you either have too much of one thing or another, many of these inborn errors of immunity actually can lead to abnormalities in some or in all of those fields. So do you like the term immune dysregulation better to encompass many of these conditions?
Yes, I like the term immune dysregulation a lot better than the others for the reason that we mentioned, but it's also a lot more ambiguous and it's a lot more vague. And you're absolutely correct that one of the things that clinical immunologists have to be very cognizant of is the language, because we have made it an either or thing for a very long period of time. And that's the problem with the term immunodeficiency. Because, as you had mentioned, it's not an either or thing. The immune system is a term, is a concept that we had made up as scientists and clinicians looking at all these various different systems that are happening at the same time. However, the more accurate way of thinking about it, if we think about metaphors and stuff, is that it's a series of levers and buttons and pulleys. It's an extremely complex machine. And when one aspect of that machine is not working as well as it should be, then another aspect will start to compensate. And that's why we see things like in Wiskott-Aldrich syndrome and honestly, virtually every single immune dysfunction or dysregulation, every single inborn error of immunity or primary immune deficiency or whatever we may call it, there's going to be some element of autoimmunity, autoinflammation, allergy, recurrent or severe infection, all these different things if you scratch the surface deep enough.
You mentioned 431 genes that have been associated with this. Is there a way that you have in your mind to sort of organize or have a framework for classifying some of these? And can you provide examples about how they present in clinic so that rheumatologists, may try to begin to understand and think, well, maybe this patient, isn't just arthritis. Maybe it's part of this immune dysregulation. How do you think about grouping, these 431 genes?
Yeah. I don't know those 430 and 431 genes. I don't need to know them because I'm not competing in allergy knowledge bowl, allergy immunology knowledge bowl. But how I think about it is going back to the basics and straight to medical school and thinking about the immune system. And the immune system can, of course, be classified into many different ways. Is it innate or adaptive? Is it humoral or is it cell mediated? Is it, quote, primary, as in, like, did it start earlier in life? Or is it secondary, as in later in life? So there are many different ways to think about it. This brings to a much, much larger question in terms of how physicians and clinicians in general, how they think about different diagnoses. And this is something that I've done a bit of research in as an educator. But the diagnostic thinking patterns that rheumatologists have are different and very distinct than those of clinical immunologists. Rheumatologists writ large, and again, I don't want to get into too much of generalizations because everyone is very different and we don't quite understand diagnostic reasoning very well. But we tend to have a culture of putting things into syndromes. So we look at things in terms of their clinical phenotypes and then work a little bit backwards from there. Therefore, when we see a patient who has, say, hitting in the nails and symmetric polyarthropathy in the absence of a rheumatoid factor, we think of psoriatic arthritis. A clinical immunologist would probably look at it differently. A clinical immunologist would probably see it more as a dysfunction of Th17. And they would probably just start from a very different starting point and get to maybe the same diagnosis or maybe not. So what I do is I toggle back and forth between the rheumatology hat and the allergy immunology hat or the clinical immunodeficiency hat or whatever you want to call it, right? In order to examine these patients who have complex issues that straddle between recurrent infections, autoimmunity, autoinflammation, all these different kind of things. And again, it's not easy, but straddling between these two ideas of doing more of a systems-based thought going back to basic immunology and more of a syndromic kind of clinical thought process, it yields a lot of insights for the patient that can then provide a kind of a pretest likelihood for genetic testing and then looking at the genetic results very closely and seeing whether there are any of these inborn errors of immunity that are showing up. Now, 430, 431, 432 by this, by the point that you hear this or more, it's going to keep on expanding. And the fact is, like, I get emails all the time from the services that we use for genetics that, hey, look, we found that there's a new association with a new disease on this patient that you had seen 5-10 years ago or such. I mean, there's no way to do some clinical reasoning and predict, the future that this is going to happen with the genetic testing, et cetera. So I don't really memorize that in so much as I just Google it. I usually go to GNOMAD, which is GNOMAD. And with some training and with some experience, you can take a look at the genetic mutations and see whether those are more likely to cause the issues than not. If you are in a place that has a little bit more resources and a little bit more collaboration with basic scientists, then you can petition them to induce some experimental genetic changes in certain animals, zebrafish, all that kind of stuff, and prove it definitively. But I imagine that most of us are not in those kind of settings. And that kind of brings to another element to what it is that many of these patients who have inborn errors of immunity, we never find out what the genetic mutation is. And so is that truly an inborn error of immunity? If you can't identify that, is that a primary immunodeficiency? Don't know. I call it that, but then some purists will say, no, that's just somebody who's just been really unlucky and getting a lot of infections.
So which are the patients that we should think about inborn errors of immunity? Is it the typical rheumatoid factor positive patient with polyarthritis? Or is it the patient that maybe has arthritis, maybe it's seronegative, maybe has infections or has had, as you mentioned, malignancies? Or how do we think about like picking up those patients? And there may be many more that we don't recognize. As you mentioned, we are good at putting things into syndromes like lupus, right? You have a little bit of alopecia, you have some joint pain and an ANA, we may say, oh, it's lupus. But that may consist of patients that have very different pathophysiology. So which are the patients that we should think about? I wonder if this patient has an inborn error of immunity.
Right. And in your example for lupus, that very well could be a complement deficiency, for example, right? So all of this is hard to identify. And that's why there's training programs, right, for clinical immunology, which I would recommend that if there's a clinical immunologist nearby, and especially one with a lot of experience with immune deficiency, then a referral is worthwhile. To pick up these very subtle hints, number one, you need to have that threshold for recognizing these conditions. So that's number one. So listening to this podcast is the first step towards identifying towards that. The second thing is, yes, there are certain things that make me very strongly believe that someone may have immune dysfunction in general. The first thing is that I try to figure out if there's a family history of immune deficiency. And that could be anything from very clearly like, oh, yes, my brother was tested for this and they have a mutation in this gene, right? That could be very easy. That's a slam dunk. However, it can be a lot more subtle in terms of if you ask them, for example, are there family members who died of infections really early? What type of diseases run in your family? If there's a very strong family history of, say, lupus, we know that there are genetic mutations, the complement deficiencies that confer a great deal of susceptibility for lupus. There can also be certain elements of, again, mixed autoimmunity and immune deficiency. We talked about Wiskott-Aldrich, but also chronic granulomatous disease. Carriers of chronic granulomatous disease can present with cutaneous lupus. So if you see that type of family history and you have somebody who's coming in with the recurrent infections or severe infections, that could certainly be an indicator of what's going on. So that's kind of like the easiest way, in theory, the easiest way, because sometimes getting family histories out of people can be a little challenging, but that is the art of clinical medicine. Other things, so classically, when we think about immune deficiency, we think about recurrent infections, which is true. If you do have recurrent infections, particularly in adults, if you have ear infections, multiple ear infections, without a structural reason for that, if you have, I think usually it's 2 or more sinus infections within 1 year, in the absence of allergies, right? I mean, if you have allergies, it's very hard to tell the inflammation apart. If you have more than one pneumonia, for example, without a predisposing reason, if you have a lot of recurrent viral infections, for example, those are the kind of things that make me think that, yes, there may be an immune deficiency brewing. But it's not just the recurrent nature of these infections, but it's the severity of these infections too. And we see this all the time in which somebody is a 30-year-old person, was perfectly fine, and for some reason, they end up in the ICU with an adenovirus infection, for example. We find that that person has an immune deficiency. So it's not just recurrent infections, but it's severe, unexpected reactions to infections as well. For example, like recurrent need for intravenous antibiotics to clear those infections. It suggests that, they need a little bit more of a boost. The immune system needs a little bit more boost for that. It can even be a little bit milder. So thrush infections, fungal infections that are occurring in the body, the non-tuberculous mycobacterial infections, for example, these can all be signs of an immune deficiency. And again, the clinical history is so important because there are many conditions that can predispose to this. So, for example, diabetes predisposes to recurrent infections. Part of that is because of the effect of hyperglycemia and hyperinsulinemia on the immune cells. Part of it is just, and I shouldn't say just because it sounds like I'm minimizing, but part of it is the neuropathy that occurs and the lack of wound healing due to poor blood supply. That technically is not what we think about for primary immune deficiency. Maybe secondary immune deficiency, not really an inborn error. So we're getting into this like philosophical kind of thing again. But these sort of questions are still really important in terms of getting a good history of infections, in terms of severity of infection, recurrent infections, treatment of infections, abnormal responses to infections, family history of infections. Those are really important. Another element to that, we're focusing a lot on the classical element of infections, but another one of the warning signs is chronic diarrhea with weight loss, because many of these conditions, so the grab bag of immune deficiency has been called common variable immune deficiency. A lot of it does present with chronic diarrhea with weight loss. So if you have chronic diarrhea and recurrent infections or severe infections, all of that, that could be a sign of immune deficiency. Alternatively, chronic diarrhea could be causing a loss of certain types of immune globulin and therefore causing more immune deficiency. So again, very, very, very complicated. And then autoimmunity, right? So especially when it comes to autoimmune cytopenias, a lot of those autoimmune cytopenias are secondary to inborn errors of immunity or immune deficiency, immune dysregulation, etc. So how does this bring relevance to the rheumatologist? Well, if you see a patient with arthritis, but they have these severe, unresponsive autoimmune cytopenias, well, start to think about if there's something else going on. If you have a patient with rheumatoid arthritis and you put them on methotrexate, let's say, and they just get so many of these infections that are completely out of step for what you would expect for methotrexate, then maybe the patient has an immune deficiency, right? It's a very, very challenging art to tease these kind of things out. But again, awareness is the first part of it. I have 4 clinics per week. And I would say that out of those 4 clinics, so probably I see or supervise maybe, 50 patients or so per week, and probably identify 2 or 3 who have some combination of an immune deficiency for which there's actionable items, right? I mean, you can give them IVIG, for example, or subcutaneous immunoglobulin, or rotating antibiotics are also an option for various different reasons. We don't prefer it as much, but certainly it may be an option out there. And it has very important implications for preventative health and for family screening, all that kind of stuff. But the fact that I see, 2 to 3 per week out of 50, that's quite a high number. And I don't know why others are not seeing it as much as I'm not seeing it. I don't know whether if there's a bias in terms of patients shuffling to my clinic for that, but I suspect that there's a mix of that and the fact that the clinical suspicion is just not there.
It's under-recognized. So you mentioned a lot of sort of the other things that are associated, the recurrent infections, the severity of the infections, the family history. And then in terms of the rheumatologic manifestations, can this be your stereotypical seropositive RA? Can this be your ankylosing spondylitis patient? Or is this more of those patients that present with some inflammatory arthritis that is more challenging to characterize, or does it matter?
Yeah, and again, it depends on the definition that you have, right, of what an IEI is, or primary immune deficiency. But yes, it actually straddles that spectrum from all of them. So if you get these kind of histories, regardless of whether if it's seropositive RA or whether if it's like undifferentiated connective tissue disease, you can find it. And I'll give some examples of this, of where a really close attention to history may be able to find this primary immune deficiency. So I had a consultation with a patient who came for, quote, fibromyalgia and a positive ANA, right? That's what it was written in the consult request. And, I took the history, and certainly this patient had a lot of chronic pain and fatigue and all these other items that would be suspicious for fibromyalgia as a diagnosis. And they had a positive ANA about 1 to 160. So nothing, again, there wasn't really a slam dunk for any rheumatological condition. But you took the history just a little bit more, and there were a few things that struck me as being unusual. And number one was that this patient had a history of sinusitis in the past that was just described to allergies, but had never actually been allergy tested. And so examined it just a little bit more, and it didn't sound like allergies to me. Again, like allergy immunology is a field and it's combined between both allergy and clinical immunology. But as I was taking the history, I didn't hear anything that sounded strongly allergic in nature, and she was getting recurrent antibiotics for this year after year.
Hmm.
So it got a little suspicious to me about this quote fibromyalgia, this positive ANA, and this now recurrent sinusitis. And then I'd gotten even more of a history that she said that when she went to the grocery store, that she would put things into her grocery cart, and as she pushed further with the grocery cart, that her hands would start to cramp up. But it was only when the grocery store started to get really full, otherwise she wouldn't have this kind of cramping. And so it was just a really strange history that did not seem to comport with fibromyalgia or really a lot of our rheumatological conditions, although obviously our rheumatological conditions can do many, many, many different things. And so I did some routine testing and we tested her calcium. That was one of the things we did. And I don't remember the exact value, but the ionized calcium was incredibly low, enough that, on a Friday afternoon, I got a phone call from an alarmed laboratory technician saying, like, look, this person needs to be in the hospital. We've never seen anything so low. And very, very, very long story short, this person had an AIRE mutation. I don't remember what the exact one is, but it's one of the regulators for the thymus. And actually, she had a subclinical variant of autoimmune polyendocrinopathy with candidiasis and ectodermal dystrophy. And actually, I forgot to mention this part on physical examination. Yes, her nails did have that kind of dystrophy that you would expect with recurrent fungal infections. So that's one that, yes, it made a big difference in her life. And we were able to get a diagnosis because we were thinking a little bit outside the box. That's kind of one, right, where those warning signs, the recurrent infections, including for physical examination, the fungal infections, came out to make a big difference. Another really kind of puzzling case, one that is a little bit more similar to what you were mentioning in terms of the more common issues. I had a patient with seropositive rheumatoid arthritis come with severe infections, and she's actually not on any medications when I first saw her. She was a very heavy smoker. I remember that, just walking into the room and just like the smell of tobacco just overwhelming me. But she didn't have a reason to have recurrent pneumonias apart from obviously the tobacco abuse. When we did some routine blood testing for her, it turned out that her neutrophils were 0.
Wow.
It turned out that she had a mutation in neutrophil elastase. And that is what led to the neutrophils being 0. Now, this is the really very fascinating aspect of this, that we did start her on a TNF inhibitor along with some IVIG because she also had some laboratory abnormalities in terms of her antibodies. And number one, her neutrophils started to pick up, which was great. Her pain started to get worse as well, presumably because it was the neutrophils that mediate pain. And she had no neutrophils before, and she didn't really have much pain in her hands. So again, long story short, the story is very complicated in terms of autoimmunity, immunodeficiency, and autoinflammation. One more story to tell you, and that is a patient that we saw on allergy immunology consults. And this was someone who was in the hospital for a autoimmune thrombocytopenia. And they were concerned about lupus for him because, again, positive ANA, 1 to 160. And yes, it's not a bad reason for consultation, right? I mean, he had some sort of mild rash that was not very well characterized in the past. And we asked him the regular questions and all of that. And it looked like 20 years prior, he was 40 years old, so 40 something years old. 20 years prior, he had episodes of these recurrent abscesses just on the arm. And these apparently were very, very, very significant, required long courses of IV antibiotics, but somehow it just kind of stopped by themselves. Very strange story. But in any case, as we did a little bit more evaluation, we realized that there was an issue in terms of his neutrophil bursts. And it turned out that he was a carrier for CGD. And that is one of the conditions that can cause lupus-like rashes. So again, you can find them. It requires this toggling back and forth between looking at things syndromically and in terms of clinical phenotypes and looking at more from an immune system pathogenesis kind of thing. I wish I could provide like a really easy, this is the mnemonic, right? The USMLE style mnemonic for this is when you can see when there are immune deficiencies. Unfortunately, I can't. But there are a lot of different conditions out there that can mimic immune deficiencies, and many of them are rheumatological in nature. One last kind of thing, I haven't seen this case, but one of my colleagues had seen this case, but this was a patient that was diagnosed with seronegative rheumatoid arthritis for years and years, was treated with all sorts of different agents, didn't have many deformities, thank goodness, but a lot of pain in small joints. And they were just unable to isolate, like, what would be the best treatment for this patient with rheumatoid arthritis. They went to one of my colleagues who's also dual trained in allergy, immunology, rheumatology. They start to get a little bit more of the history. Again, very, very, very long story short. Turned out the patient was positive for parvovirus B19. Parvovirus B19 is something that usually is a self-limited infection, but causes symptoms that are very similar to rheumatoid arthritis.
Mhm.
In this patient, because she had deficiencies in T cells and NK cells, natural killer cells, that is, she apparently was unable to clear the parvovirus B19. And we were able to give IVIG, which is intravenous immunoglobulin. Intravenous immunoglobulin is antibodies for many different people. Some of these people probably had antibodies against parvovirus B19. And I think it was 3 or 4 rounds of IVIG. And the patient started to have dramatic improvement in their joint pain. And it stopped.
Amazing.
I mean, we effectively cured, in quotations, because this is a podcast, cured the rheumatoid arthritis that was there. So it's a good example. All of these are good examples of how arthritis and rheumatology in general, these kind of symptoms and signs can mask a immune dysfunction that's there that may be genetic in nature. We may not find the gene, but some sort of inborn error of immunity of some sort.
Those are fantastic stories, Bharat. Now, as you were talking, I was thinking about many patients I've seen in the past that are like, I wonder if he has, some sort of immunodeficiency or contributing to their presentation. So I guess the first part is to have a high degree of suspicion for these syndromes. And you base that on the history, on the physical exam, on the family history. So what's the first step that rheumatologists should take when we are wondering whether one patient that we're seeing in clinic, whether or not they have an inborn error of immunity? What are the tests, the laboratory tests that you would recommend us sending? Is it 431 genetic panel? Is there something else that we should be doing instead?
That is a great question. So I'd still say that, if we make a scale, let's say from 1 to 100, right? And we're trying to get to 100, which is the diagnosis of an immune deficiency. Probably 80 points of that is going to be the history and the physical examination. And
Okay.
the 20 remaining points are going to be certain laboratory tests. Again, I wish I could give you a nice set of laboratory stuff to send. It really depends upon your location, the resources and availability, and of course, the clinical presentation. In many areas, where genetic testing is like widespread, it's as common as doing a complete blood count. Yeah, send for the 430 some odd genes. I mean, it's great if you have the ability to do so. If you don't, and if you want to complement that, even if you do have access to the genetic testing, here's what I usually start off with. So first of all, and these are very common and you probably do them in your practice anyway as rheumatologists, but a CBC with differential. So you can check for different cytopenias there. I usually do a complete metabolic panel, not only because it is helpful sometimes for identifying a primary immune deficiency that has metabolic effects, but also there may be secondary causes of immune deficiency. Again, like with all the caveats that we talked about earlier in this podcast, I usually do a urinalysis as well. If I get a particular history of immunoglobulin loss, say through the urine or through the stools, then for the stools, I'll get like an alpha-1 antitrypsin, but those aren't blood tests, obviously. If I am hearing a lot more autoimmune kind of issues, especially if it's like more lupus-like, I tend to get complement levels. So I usually get C2, C3, and C4, and a CH50. Other people have different ways of looking at it, but those aren't universal.
Does the CH50 add anything if you get a C3 and a C4?
Yeah, it's controversial. It's personal. There's a lot of personal practice. My feeling is if the clinical suspicion is very high for a primary immune deficiency and the CH50 is 0, then you have diagnosed it. But if it's anything less of that, then you still got to keep on digging.
Got it. And C2?
Yes. I usually get C2 as well, and that's probably more a force of habit because there's all sorts of other things that we look for C2. In allergy immunology world, we look at C2 and C4 because of hereditary angioedema. In rheumatology world, we look more at C3 and C4. I do all of them. C2 deficiencies are present and they do contribute to lupus-like diseases. So I think it's reasonable to do it, but I also understand like it's not necessary, it's not mandatory.
Got
And
it.
there is still quite a bit of controversy about whether or not you should do that. The other ones that people get really excited about in general are the antibodies. So number one, I do get the four typical classes, IgG, IgA, IgM, and I usually do IgE, although again, you may not want to do it unless you have a reason to suspect a condition like hyper IgE syndrome. I usually check the numbers. I do not check the IgG subclasses unless there is a big reason to support that. Things go back and forth, but right now the community of clinical immunologists really do not believe in specific IgG subclass deficiencies. Usually they are a manifestation of a much different type of immune deficiency. So for example, IgA deficiency often is associated with IgG2 deficiency. So I usually don't do the IgG subclasses unless there's a reason, right? If I'm for some reason thinking about IgG4 related disease and I want to check it, then I'll go check that, right? That is the quantitative element of the antibody evaluation. The qualitative element is a little bit more difficult and it's a little bit more challenging. In the past, what we've done is we've given vaccines to patients and we have checked their antibody responses at the time of vaccination and then usually about 4 to 8 weeks afterwards, and if necessary, beyond that time. And these vaccines include measles, mumps, rubella, tetanus, diphtheria, and pneumococcal. They all work in slightly different ways. Pneumococcal antibodies or pneumococcal vaccine in the past, predominantly, we've given the polysaccharide vaccine, and so it can help in terms of understanding those antibody presentation aspects of immune deficiency. Of course, the issue now is that we have newer conjugated vaccines that are a mix of protein and polysaccharide, and so we don't get nearly that degree of purity in understanding whether if the antibodies are going to be elevated because of antibody presentation or because of other processes. However, that is classically how we've been done it. I'm sorry if I'm going way much into
This is great.
the weeds about that.
So you mentioned that's how it was done.
Yeah.
Does that mean that you no longer do that, or you still do that but
Well,
sort of rely less on it?
I still do that, but it depends on the population because if it is somebody who has already received the conjugated vaccine, then it becomes a lot more challenging in order to find a qualitative defect. And so I rely, number one, much more on history. Number two, a little bit more on those other antibodies that we can find. And number three, sometimes I just do random titers. And if the titers are low, despite giving a very, very good vaccine, one that really prompts very robust responses and vaccine responses, then I think that, well, probably there's a problem with the antibody production or something else in terms of antibodies. So again, like this is very complicated process. It's something that can be started in the rheumatologist's office, that is giving the vaccine and checking the baseline titers and then sending it to an immunologist in the meantime. And that, of course, depends upon the availability of immunologists, and that depends upon their wait time as well, because immunologists, just like rheumatologists, are very much in short supply.
Yeah. So one more question. How about B and T cell subsets? Is that
Yes.
helpful? Like I've gotten that sometimes, and it is so hard to interpret. It's like memory B cells, this, and CD positive, whatever that. Like I have a very hard time understanding those results.
Yes, and that is very much a challenge. I didn't mention flow cytometry in there, but you are absolutely correct. Flow cytometry has a very big role to play, especially when you are considering conditions that are more in terms of T cells. The majority of immune deficiencies, as far as we understand, are more B cell mediated. That's why I'm focusing more on that. But if you're thinking more T cell mediated, then you have flow cytometry or other subsets, then flow cytometry is important. Yeah, it requires going through fellowship interpret to interpret many of those things. It depends a lot on what you're trying to look for. So, for example, if you're looking for autoimmune lymphoproliferative syndrome (ALPS), which does present with many rheumatological complaints and signs and symptoms, that it really is necessary. I mean, you will find those cells on the
So
flow
the
cytometry.
double negative T cells or
Yes.
yeah.
Yeah, so you will find those. But for other cases, you may not find anything, or you might find really non-specific kind of findings on it. So it really depends upon that. I usually, when my colleagues ask for advice regarding that, I usually say you should probably send them to a clinical immunologist to take a close look at that flow cytometry. And again, like a lot of it requires the history and clinical presentation of that in order to correlate what's going on with flow cytometry. There are other labs too that are helpful. So flow cytometry, I think about as a quantitative test for cell function. However, there are many qualitative tests for function of these cells as well. They're not routinely available, but if necessary, you can send them. Lymphocyte transformation assays, natural killer cell assays, for example, they are available, but they're not necessarily available where you may be. But they're all very, very helpful because many of these patients, they have normal numbers, but their functionality is off. And that's another challenge that prevents people from looking at the different immune deficiencies.
And the last question regarding workup,
Mhm.
do you ever get cytokine profiles and is that helpful?
Oh boy, this is something that's probably going to get me in a bit of trouble because there are way too many opinions on this. Cytokine profiles I do occasionally get in the inpatient setting, especially when there are these patients with HLH, because it can help in terms of finding what kind of cytokines are driving the storm, what kind of cytokines are being recruited in order to mitigate the storm. And HLH, to my mind's eye, is a form of immune dysregulation that may be, quote, primary, or it may be, quote, secondary in nature. However, for the majority of patients for immune deficiency evaluation, I usually don't get the cytokine profiles. It's just one of those things that has not yet been finessed to a way that it can be worthwhile in the clinic. I generally don't, but I know that there are other people that do use it. They have cases in which it's been very helpful for them. But in my experience, it hasn't been particularly too useful as compared to the other.
Yeah.
And it's still quite expensive. I mean, it's, somebody's got to pay for that. So I tend not to use it. But, I may change my practice in the near future. It depends on where the science takes us.
Yeah, very good. I think I agree with you. Patients with HLH, MAS, some of those cytokine profiles like the soluble IL-2, CXCL9,
Mhm.
IL-18 may be useful. I sometimes get it when I'm thinking about a patient with autoinflammation, but even then it's hard to sort them out and you may have some elevations and you don't really know what to do with them. So it's
Yeah, a lot of it, again, I'm probably going to get into a little bit of trouble, but a lot of it sounds like palm reading, where it's like, oh, your IL-18 is elevated, therefore it means that you have this,
yes.
and there's no way how to necessarily prove it, but we construct these stories in our minds because of a finding. And it may not necessarily be a very scientific way of looking at it, but it's a very human way of looking at these kind of things. So,
Love it. Let's switch gears slightly towards treatment and management of these
mhm.
patients. So, let's say your patient with arthritis turns out to have an inborn error of immunity. Should this patient be managed by an immunologist, by a rheumatologist, both? I also know that there are some clinics that are starting up of immune dysregulation,
Mhm.
right? Where maybe you have multiple providers seeing, the same patient at the same time. How do you think these patients should be managed?
Yeah, so I think that it should be both a rheumatologist and a clinical immunologist. And there really has to be that kind of negotiation between the two about where one person feels comfortable in treating a condition and where the other person feels comfortable. In my clinic, because again, I'm dual certified, I don't have that problem, but I know that when a patient gets transferred to another provider who may be a rheumatologist, they may not necessarily be comfortable in managing many of the treatments that we use for immune deficiency. And so they get two doctors instead of necessarily one. And this is why I would plug actually more of these programs for dual certification in allergy, immunology, and rheumatology, because that's the only way to really understand these conditions in a clinical setting. But in any case, going back to how to manage these patients, number one, the treatment options right now are fairly limited for the vast majority of patients. So let me just mention kind of the 4 or 5 options out there, right, for these patients with rheumatological conditions that may also have an inborn error of immunity. So number one is making sure that they are up to date in terms of preventative stuff. I'm using stuff in the broadest sense of the term, but things like vaccines.
Yep.
Very, very important. They may not necessarily have responses to vaccines, but they may confer some protection. Have to be very careful though, because certain immune deficiencies, you cannot use live vaccines in them. So you have to be very, very mindful of that kind of nuance. But that stuff also includes things like reinforcing frequent hand washing, talking about, nobody likes to hear about this anymore, but about that 6-foot distance and the bubble, et cetera. It depends on the severity of infections and all of that. That's option number one. Option number two is the intravenous or now subcutaneous immunoglobulin. And those are patients that have antibody-mediated disorders. So people who have T-cell-mediated disorders, probably not going to benefit as much as those that have low numbers of antibodies, especially IgG, or who have low function of IgG. So that's another option out there. And that's, of course, a personalized decision, as with all of these. The third is recurrent antibiotics. This is something that's fallen out of favor for a very good reason, but it is something that is useful for people who are getting antibiotics anyway on a very frequent basis. And so just do it ahead of time instead of doing it afterwards may not be a bad idea. And when I mean antibiotics, obviously I refer to antibacterials, but it may also be the same for suppressive antivirals or antifungals as well. And there's a lot of benefits, but there's a lot of drawbacks to that approach as well. So that's kind of the 3 options for the majority of folks. The fourth options, it requires a lot of finesse, but there are some genetic mutations that may be amenable to certain types of biologic medications. So I've had patients before that have very rare mutations that have responded well to rapamycin. And so you think about it as like, why would you give a person with immunodeficiency, an immune suppressant? Well, in this case, there was a pretty good reason for it, and it actually helped reduce the number of infections and it helped reduce the lymphadenopathy that was really consuming this patient's quality of life. So that's certainly possible, but now we're getting more into the really you have to be very, very careful in terms of what you're doing. And then the fifth option, and this is not routine, and this is not anything that's going to happen in the near future, but maybe in the more far-flung future, is things like stem cell transplants, CAR T therapy, which they're probably coming, right? I mean, not just for rheumatology, but for immunology as well at large. But those are the things that are kind of out there. I wouldn't stop the medications that we would use, the quote immunosuppressants. I've actually stopped using the term immunosuppressants. I say immunomodulators because we also know that very severe and uncontrolled rheumatologic disease also predisposes to recurrent infections.
Sure.
And that's been shown in large registry data in various different places. And it's been shown experimentally as well, right? In a very colloquial kind of sense of the term, if these immune cells are fighting against the body, they're not fighting against infections. So retraining the body using immunomodulators may help to, ironically, or in a contradiction, it may help to actually reduce the number of infections and help reverse an immune deficiency.
Fantastic. It sounds like we should send many of these patients to you to help us manage. Tell me a little bit about, you sort of hinted at these programs that have combined allergy, immunology, rheumatology. Can you talk just briefly about where those programs are and how people can get into those?
It's very, very few, but the few that I know of are number one here at the University of Iowa, where I graduated from. And, I'm the rheumatology program director, so conflict of interest right there. But that's one program. It's probably one of the older programs. We've been doing this for about 11 years. So certainly that's an option out there if you're interested.
How long is that?
It's 3 years. So it's a 3-year program because there are common requirements that are in between rheumatology and allergy immunology, each of which are 2 years. You can be eligible for board certification in 3 years. So that's one of the places. And again, it's a great program, and we have a dedicated pathway towards that. The other places, you have to be kind of mindful that it comes and goes, and I can't vouch for whether if they're still available or not. But Yale University has one that is, I believe, 4 years, so 2 years of rheumatology and or allergy, and then 2 years of allergy and or rheumatology, which is another pathway to doing it.
Mhm.
In the past, I believe Baylor and University of Kansas or Kansas University, not sure, I apologize. University of North Carolina, I don't know if they currently have a program or not. Previously, the folks in Buffalo and Rochester used to have it too. And remember, this is for adult rheumatology and allergy immunology. There are other programs there for pediatric rheumatology and allergy immunology out there, which I'm less familiar with, but I'm sure you can find them online. The only thing I can really vouch for is that, the University of Iowa has a program, and we're always
And their program director is okay.
and the program director is okay.
And then
a little rough around the edges.
for many of us, that's too late. I'm not going to do yet another fellowship. Where can I learn more about these inborn errors of immunity? Can you provide some resources?
Yeah. So the Clinical Immunology Society, CIS, has a great website that can help clinicians in particular to get more education on immune deficiency or inborn errors of immunity. In addition to that, there are other resources at the AAAI, so AAAI, which is the American Academy of Asthma, Allergy, and Immunology. They have a lot of information on there that is both patient-facing and also clinician-facing. And the Immune Deficiency Foundation as well has a lot of resources that is a lot more patient-friendly in general than the other sources, or they have a lot more of them, I should say. So those are some great resources to learn more about immunodeficiencies. Things are changing at a rapid pace. So I wouldn't really memorize a lot of things right now. Just get the good gist of it. And I think the biggest objective for rheumatologists is to recognize when it would be important to consider this and to how to start the workup for these conditions so that a clinical immunologist can tip their hat and say, thank you, rheumatologist. You've really helped in terms of facilitating the quality of care for this patient.
I love it. And if you provide us with those resources, we can put them on the links to this show.
Sure.
Bharat, this has been a wonderful conversation, but I couldn't finish it without giving you the final Jeopardy question of the day. Were you a 3-time Knowledge Bowl champ?
I was, yes.
Amazing. So this is an actual final Jeopardy question from several years ago that has something to do with what we're speaking about today. Are you ready?
I'm going to be as ready as I ever am.
Here we go. Final Jeopardy. And by the way, the category is Inborn Errors of Immunity. This condition presents with rash, small vessel vasculitis, and interstitial lung disease. It is caused by mutations in TMEM173. And then we play the music. Bharat, what is your wager?
$0. There's a reason I'm not participating in Knowledge Bowls anymore.
Care to put a guess?
I mean, I'm gonna guess savvy.
Very good. What is sting-associated vasculopathy with onset in infancy? Look at that. You still have it.
I should not have wagered $0 then. But
Yeah.
I still maintain that I am retired from Knowledge Bowl. I am going to be a judge this year for ACR Knowledge Bowl, but I'm no longer competing. I'm going to end up on top.
You still have it, Bharat. It's been a pleasure catching up with you and learning a lot about how to recognize these inborn errors of immunity. I really appreciate all your time and your wonderful philosophical thoughts about this category of diseases.
The pleasure is all mine.
Well, there you have it. I hope that this conversation provided you with better understanding of the immune system and how patients with inborn errors of immunity may present with symptoms mimicking rheumatic diseases. Of course, better awareness of these conditions and early diagnosis can significantly impact patient outcomes. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all the other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep exploring the complexities of immunology. And of course, stay healthy.